Okay, thank you, thank you. All right, well, welcome to our multimodality imaging conference. I'm Dr. Valeria Duarte. I'm one of the adult congenital cardiologists and cardiac imagers at the Houston Methodist. Today we are going to go over the third lecture of our series. And we are going to focus on tetralogy of Fallot. So, as we've done with all the lectures we've done so far, we will focus in this specific congenital defect, but we, at the same time, will review a general approach. We'll use this as an example to think about others. We did this with D-loop transposition of the great arteries during our last session, and before that with shunts. So tetralogy of Fallot, we're going to define the general approach, the benefits of each imaging modality, and then we'll discuss the importance of the knowing the long-term complications to understand what we're looking for. So if you can see here, this is from Richard Jonas, a congenital surgeon, and this is data from Boston Children's looking at surgeries from 1997 to 2001. And you see that here, number 2, this 15.5% of the operations performed at the pediatric hospital in that time frame were interventions of the pulmonary outflow, okay? With tetralogy of Fallot being the most frequent one. Conduit revisions being the next one, and other types of RV reconstruction being the third. And it has to be, the first one is tetralogy of Fallot repairs, but the second and the third maybe just redo surgeries in patients with tetralogy of Fallot. Let me just put my pointer because I'm pointing here, but I just realized that you guys cannot see what I'm doing. Okay, great. Okay. So as always with all the congenital studies, we need to know the native anatomy. We need to review the surgical history of the patient, understand the different surgical approaches for each condition, and know the strengths of each modality, and before protocoling, know if we're going to be able to answer the question we're being asked. And always use language that is appropriate for different providers, right? Pediatric cardiologists, adult cardiologists, and different nomenclatures when it's pertinent to. So tetralogy of Fallot, it comprises 4 distinct, a combination of four different findings caused by one congenital malformation, congenital defect. So could you help me refresh what were the 4 features of tetralogy of Fallot? Yes, Gabriel?
VSD, ventricular hypertrophy, pulmonary stenosis, and overarching aorta.
All right, he gets an A. So we have a VSD, right? RVOT obstruction, a RVH, right ventricular hypertrophy, secondary to the RVOT obstruction, and overriding aorta. And all of this are caused by one problem, which is? Yes, anterior malalignment of the conal septum. So that's the one defect that the one problem that explains all. So the conal septum or infundibular septum, very simplistically, lies between the outflow tracts, the LVOT and the RVOT. And in tetralogy of Fallot, for those that can see my hands, we have anterior malalignment of that portion of the septum. And as you know, the RVOT is anterior, so this malalignment leads to RVOT obstruction. It leads to the ventricular septal defect here that and the RVOT obstruction leads to the RVH. And also, as we deviate the coronal septum, we cause the overriding aorta, if that makes sense. Is that clear or no? This is the key feature because we're used to repeating those 4 things, but they're very closely related, and we need to know that. Okay, well, great. Tetralogy of Fallot is the most common cyanotic congenital heart defect. So you will see this in your practice, in your general cardiology practice. As you know, most patients with ACHD fall out of care, and most of them are seen by congenital cardiology practices. And then I'll trust you to get them back in care. Okay, so when we look at imaging studies to follow up patients with tetralogy of Fallot, we need to focus on long-term in adults, the patients that we will be seeing. Our number 1 priority is always the pulmonary valve. The most frequent long-term complication of tetralogy of Fallot is PR. Thanks, Joy. Pulmonary regurgitation. So most patients with tetralogy of Fallot will have significant pulmonary regurgitation and will need a pulmonary valve replacement 1, 2, and sometimes more times in their lifetime. Patients with tetralogy of Fallot nowadays have life expectancy very similar to the general population. So they live many years. They live through pregnancies. They practice sports. We have an Olympic athlete with tetralogy of Fallot. You guys know him?
Yes. He's a skateboard.
You guys know? No?
Something like that.
A snowboarder.
Snowboarder.
Yes. Yes, Team USA. Yes. Sean, what's his last name? I forget. Sean White. Yes. How about that? Yes. 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 So that's just to put things into perspective, because these patients do better and better. Nowadays, most patients born with tetralogy of Fallot are operated at what age? Do you guys know? Today, contemporary. Hmm? Yes, before they're as infants. Yeah. Mm-hmm. Okay. So then the next thing we look at is right ventricular size and function. Pulmonary regurgitation, do you think the surgeons didn't know that the patients after tetralogy of Fallot repair that they are left with pulmonary regurgitation and this just happens, or this is something that is known to them as the patient leaves the OR? Huh? Yes. Yes, exactly. So here, if we go back here to review what the tetralogy of Fallot entails, so we said we have a VSD and we have RVOT obstruction. We can have patients with tetralogy of Fallot in whom the pulmonary valve has normal function. So in those patients, we do a repair that is called valve sparing repair. That's right. So in those patients, only the RVOT obstruction is released. So tetralogy of Fallot involves 2 major things. First, the VSD closure, like you can see here, and second, the resolution of the RVOT obstruction. If the pulmonary valve is not affected, then it can be a valve sparing repair. In general, these patients have an RVOT patch that looks like a triangle here, like half of this. And that spares the valve. It happens, the patch is right below the pulmonary valve annulus. When the pulmonary valve is involved, meaning the annulus is too small, then they have to disrupt that annulus and put a larger patch, right? That extends from the RVOT across the annulus into the main PA. And this repair is called transannular patch repair, which is what is depicted here. You can see this big patch. So the patients that are more likely to struggle with severe PR, that will struggle with severe PR, are the patients that undergo this transannular patch repair. In the past, all of them used to get this repair. As surgery has evolved, the valve is spared in those patients that are suitable. Okay, so in tetralogy flow, cyanosis is caused by what? What's the RVOT obstruction, the lack of pulmonary blood flow. So in the surgery, the first priority is to remove the RVOT obstruction. In pulmonary regurgitation, does it cause issues in the acute setting, in the short term? PR? No. PR is very well tolerated, and it takes decades. Usually we start dealing with the consequences of chronic significant PR in the 20s, 30s, 40s even. Okay. Do we operate on all the patients that have severe pulmonary, repaired tetralogy flow and severe pulmonary regurgitation? Yes or no? That's right. Like Rudy is saying, it depends. It depends. Why not? If if something is wrong, we need to fix it. No, it doesn't work like that. No. So we fix it in patients who have symptoms. Number one, yeah, because data shows that replacing the valve in patients who are symptomatic shows improvement from that perspective. But then in the absence of symptoms, as you know, patients with congenital heart disease, are they very reliable at reporting their symptoms? No. No, Sita is saying no. She knows a ton of them now. Yes, so no, then why is that?
Because they have compensated for that whole life.
They have been living with that equipment for their whole life. So that's very different from a patient who had a normal heart and had a heart attack, and then the week after says, oh, I cannot go upstairs in my own house as they used to. So because of that, we objectively assess their exercise capacity with what? VO2 max, yes. Cardiopulmonary exercise tests. I think we do them more frequently than the heart failure team. So that's why, because of the symptoms. So we replace the valves in patients who have a significant pulmonary regurgitation and symptoms. And in the absence of symptoms, this is dictated by the RV size and RV function. So that's the second most important thing. So do we correct the pulmonary regurgitation at any level of RV enlargement like we do with shunts? Yes, let's say I have severe PR, asymptomatic patient, severe pulmonary regurgitation, and mild right ventricular dilation with normal RV function. Some says no. I agree with some, but why? Like my son tells me all the time, but why? Huh?
Because there's enough time that you can keep repeating.
That's right. When we replace the pulmonary valve, we replace them with what type of prosthesis? Bioprosthetic valves, yeah? And do they last forever? No. In fact, these are younger patients, and the wear and tear has been shown to be less in these patients, yeah? So we don't want to do it too early, because once we replace the valve, the clock starts ticking, and then that valve may degenerate over time. Okay.
How long do you anticipate the valve lasting normally?
So in general, we quote our patients 10 to 15 years, yeah? Bioprosthesis, yes. There are, some patients with inflammatory conditions that may degenerate them faster. So that's that. So that's one of the reasons we don't do it earlier. We wait until the RV dimensions are severely dilated. The cutoff for the guidelines are 160 milliliters per meter square. So we index. So this is very important for the boards. Because we base this, we index the RV end of diastolic volume to body surface area. And our cutoff is 160 because that was what the studies showed, that there was still potential for recovery. Yeah.
You're not using echo as volume, right?
The gold standard is MRI.
And on echo, you can't measure reliably.
Well, on echo you can measure, yes. Yes, you can measure quite reliably. You just need, you need 3D and yes. And the studies are with MRI. Right now the gold standard is MRI, so we do MRIs in all these patients. Okay, then it's very important to document the RVOT dimensions. Why is that? Who cares about the RVOT dimensions? Huh?
Measuring our stroke volume.
Well, stroke volume is important, yes. Yes, to calculate that, yes. But in this patient, in this population, has a more pragmatic reason. Rudy?
Because you have to, you want to plan, if they have stenosis there, put a conduit, or if you want to do a transcatheter, depends.
Yeah.
Diameter.
Yeah, that's right. So you're looking for what type of valve replacement you're going to do. Right now, thankfully, we have newer valves. We have transcatheter options for these patients. So we have surgical options and transcatheter. And the RVOT dimensions are key to defining who will be a candidate for a transcatheter option if that's what the patient and their cardiologist desire. Okay, we also look at LV size and function. As you know, when RV enlargement and dysfunction is significant, it will affect the LV. And more attention is being put into synchronization in this very dilated right ventricle. So CRT is being investigated heavily now by the ACHD EP enthusiasts. And then we look at the VSD. Yes, we look for residual VSDs. Very infrequent, but we do see them. Okay, so the tetralogy of Fallot, are they all the same? Yes, so that's the hard thing about congenital heart disease, that not, even patients with the same condition can be very different. So when we are in the face of a patient with tetralogy of Fallot, what things can be different? Let's start with anatomy.
Size of ESD or severity of RVOT obstruction.
Yes, so the key thing is the severity of the RVOT obstruction, right? You can have patients who you can have patients who have tetralogy of Fallot and they are not cyanotic at birth, yeah? And then on the other end of the spectrum, you can have patients with tetralogy of Fallot who have pulmonary atresia, yes? So no blood flow at all. So those patients, if they are pink and then they turn blue in a few days, what happened? The PDA closed. So they're fully dependent on that PDA, and when that's done, yes. And then we have, on the other extreme, you have patients who that may not have an MPA, a main pulmonary artery developed. And you may have patients who have discontinuous branch PA. So here, these are continuous, right? The LPA and RPA are talking to each other. But we have patients who have discontinuous pulmonary arteries, branch pulmonary arteries. And then we have patients who don't have identifiable pulmonary arteries at all. And what fits the lungs in those patients? Aquila, louder. Collateral vessels, and what do we call them? We call them MAPCAs. So at the end of the spectrum, we have the most severe version, which is tetralogy of Fallot with pulmonary atresia and MAPCAs. MAPCAs stands for major aortopulmonary collateral. Yes, and these are all abnormal vessels that perfuse the lung, and they originate from where? From the aorta. And there is a very, very hard and challenging operation that is performed to do the repair. Imagine the repair in these cases involves reconstructing the main PA, the branch PAs, and disconnecting all these anomalous vessels from the aorta and connecting them to the newly created main PA and branch PA, yeah? And that's called unifocalization. It's very challenging. And these patients may develop something down the line that is not very frequent in tetralogy follow. Hmm? Yes, that's very true. Hemoptysis is true. But pulmonary hypertension. Imagine this vasculature is very abnormal, yeah, from the get-go. Yeah, so whenever you see a patient, for those of you going into advanced heart failure, a patient with tetralogy follow being presented for heart and lung transplantation, then you will know that probably this is a patient who had tetralogy follow pulmonary atresia in MAPCAS who underwent unifocalization. In general, tetralogy follow patients don't frequently present with pulmonary hypertension.
Is there like conduits they're using for the pulmonary artery substitutes?
Yes, yes, homographed. Yes, and from a transplant perspective, what's the issue with that? Huh? With homografts? Yeah? Sensitization, yes. Yes. So another thing, another layer of complexity. Okay, so here you're not used to looking at this, but I love showing it to you. So this is what congenital echoes look like in the newborn. So you know, in pediatric cardiologists, they use them. They look at the images in a different orientation than we do, but you guys can understand this, yes. So this is equivalent to your 4 or 5 chamber views. So which ventricle is this? Left ventricle, yes. What is this? Right here, right here. This is the LVOT, thank you. What is this right here? The aortic valve, and right below it? VSD. What do you think about the relationship? This is the interventricular septum right here. This is the crest. What do you think about the relationship of that crest of the septum and the aortic valve in the aorta?
50% overriding.
Yes, so you see an overriding aorta, yeah? All right, well, great. You wanna let's add color. So this is how this gets diagnosed, right? And then you see a flow acceleration here in a second. What do you guys think that is? All right, so I'll show you a close-up on that. So this is very similar to the way you look at things, right? This is the aortic root, yes? Yes, and you can see here what is this? Oh, what do you think are this? Bifurcation. Yes, so of who? Arteries, yeah, so okay, that's right. So this is RVOT, MPA, and branch PAs, yes? Any comments about the PAs? Are they, yeah? They look small, they're hypoplastic, that's right. So that's very important to look at. And there you see the flow acceleration, right? You agree? This is the RVO3 obstruction here. We confirm it with Doppler.
So in congenital echo, you only flip the images in the 4-chamber view or all the views?
Oh no, they flip them all. Yes. 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 The reason why they're flipped it's because in congenital heart disease things are not in the standard position, so it helps understanding sightness when you use their approach. It's easier to understand what is right and what is left and the relationships. So that's why. Okay, and then here, any observations about this one? Huh? RVH, right? Yeah, yeah. Yes, and septal flattening. Yes. So this is something that I will never say you will never see, because you have. But in pediatrics, that's how it's diagnosed at birth. And so in the adult patient, imaging tetralogy follow, it's a different story. So they first were looking in general at repaired patients. So we look at different things. And on the other hand, these are patients with scar, with increased body mass index, and so it has a different set of challenges beyond the diagnosis. So, sorry. So here, this is a patient with repaired tetralogy of Fallot, right? And when you look at your parasternal long axis, if you really pay attention, you will see that this is the interventricular septum, yes? And this is the crest of the interventricular septum, yes? This is the aortic valve here. And what do you see here? A VSD patch, okay? You will see different levels of aortic overriding in patients with tetralogy of Fallot, because we should not think that the anatomy will look normal just because they had repair, right? They correct the physiologic issues, but they don't make it look normal. Yeah? All right. So imaging the right ventricle is very important in tetralogy of Fallot. So sometimes when you look, you obtain your usual 4-chamber views. Your RV may be foreshortened, so you have to perform dedicated imaging of the RV. Most patients will have some degree of RV dilation. The RVOT and the pulmonary valve are critical, and you will have different levels of pulmonary regurgitation, and you may have less frequently pulmonary stenosis. Pulmonary stenosis is more relevant, and RV systolic pressure is very relevant in patients who have had what type of surgery in tetralogy of Fallot? Yes, in patients with tetralogy of Fallot, in which patients we really need to try to obtain an RVSP, in which patients it's super important. No, in patients who have had conduits, yes, patients who have RV to PA conduits, right? So usually patients with pulmonary atresia, their repair will involve a conduit that, like we discussed when we discussed Rastelli last time, the patients outgrow these conduits and then will need to be revised several times in their lifetimes. So patients with conduits, by the time I meet them, they usually have 1 or 2 revisions, okay? Okay, so what do you guys think about the pulmonary valve here? Yeah, so that was another one. Yeah, so that one that one is looking pretty good. So let's look at another case.
Free PI.
Hmm?
Free PI.
Yes. Well, what does she mean by free PI? Free.
Severe differential.
Yeah, and just dictated by what?
Filling the RT of the whole RT.
Flow is dictated by what in any given situation? Pressures, yeah. So dictated by the pressures between the RV and the PA. So when you have patients with, free pulmonary regurgitation or severe wide open pulmonary regurgitation, sometimes when you repeat MRIs, the regurgitant fraction may be a little lower one day compared to 3 years ago. Did it get better? Huh? If the regurgitant fraction is lower in follow-up MRIs with wide open PR, did it get better? It's less severe now? Yeah, what happens is your RV may be thicker. So the PR time may be less, diminished, yeah? Mm-hmm. So pay attention to pulmonary regurgitation. You need to go frame by frame. It's very different from AR. I many times see patients, it's very quiet on exam because it's a very short murmur, very short. So in all patients with tetralogy of Fallot, just be very, very critical about that. And I see many patients that come to me and the echo says mild PR, and it's truly very severe PR. So you may be deceived because just like the murmur is short, the regurgitation time is short. You don't have, and it looks laminar. So you need to really go frame by frame, slow down, use 3D, and really also use spectral Doppler. Look at the branch PAs, like here, to look for flow reversal, and then here this is spectral Doppler of that patient that we were just discussing. Any features here that tells you this is severe?
Just to start coming back as it's going forward.
You need to say it louder. Huh?
The densities are similar going forward.
The densities are similar. I love it. Yes, I usually get that one last. Great. So this is forward flow and this is backward flow, and you can see that the backward flow is pretty dense. Yeah? The regurgitant is as dense as the forward flow. What else? Huh? Yes, sir. You need to say it louder. I cannot hear you. Oh, that's right. Yes, and the envelope. That's right. You're absolutely right. And then usually the PR envelope looks like what geometrical figure? Trapezoid. And in severe PR, it is a triangle. That's right. Just like you see there. Okay. It's important to look at the branch PAs, the main PA and the branch PAs, and assess there too. All right. So let me show you this. This is a 39-year-old patient. Comes to your echo lab, and you get this parasternal long axis view. Is this patient similar to the ones that we just reviewed? Cases 1, 2, and 3? No. What's the difference? That's right. Where there was a patch that is supposed to be here. You see the overriding aorta, you see the crest of the septum, you see the RVH. This is one view that is giving you all this information. So this is an adult patient who is unrepaired. And I'm going to show you the RVOT just to put all your questions at ease. Yes, so this is a patient that was born outside the US. So you will see patients who are unrepaired. It's infrequent. It's obviously not those extreme severe cases, but you will see them. This patient presented to us unrepaired, and he had also familial polyposis, so he was very anemic, and in that setting he was having cyanotic spells and was very symptomatic. As you know, patients with cyanotic conditions, they rely on what on erythrocytosis, not polycythemia, yeah? Erythrocytosis, right? So yeah, in that setting. So he was repaired at age 39 and did very well. In his case, because he used an adult, he got a new valve, a valve replacement, a new pulmonary valve, and the RVOT was resected and augmented with a patch, and then the VSD was closed, and he's doing great.
So, what's the second picture?
Yes.
What are we looking at?
Oh, we're looking at the RVOT.
So what's on the right side of the jet line? Like this, next to the jet line.
Oh, what do you think?
Because I would expect the aorta to be on the other side, right?
Alicia, do you want to help him?
I can tell you because I know this case. And the person who scanned the patient was doing like an intermediate view and got this view of the RVOT that was the best.
Yeah.
But it's an intermediate view.
Yeah.
To the right, the aorta is to the right in that view.
Yes. Yes.
Sorry, to the left.
And remember that also the anatomy is also different. Yes. Yes. But this is the only pre-repair echo that we have for this patient, so that's what I'm showing. Okay, so we use MRI a lot in patients with tetralogy of Fallot. And as you know, MRI is very good to estimate flow across semilunar valves. And we do that by defining a region of interest yes, and then measuring flow, forward and reverse flow. So what do you think about this patient? We're looking at the pulmonary artery flow. Yes, patient with tetralogy flow, pulmonary artery flow. In general, just like you see in the aorta, you should see just pulsatile forward flow. Is that the case here? Yeah, very similar to what? To the echo pattern that we were looking. Yes.
Think about the continuous wave across the embolic valve that goes down below the baseline, and then everything that's regurgitating is going to be above the baseline.
Yes, yes. So this patient, you can see that in the color too, right? Yeah? In sure access, right? You see blue and red, yes? So bidirectional flow, this is also a patient, looking at it, a patient with severe pulmonary regurgitation.
Looks like more is coming back and going forward, right? Just in terms of the area under the curve?
More is coming back than going forward. Is that possible?
No, but I'm saying that's what it looks like. Based on the area of the curve.
Yes. No, not truly. But you can have in 50, 60. You know, we define, and which I think well, this is just my opinion. In semilunar valves, regurgitant fraction of what is considered severe? 50%. Do you think that's too high or too low of a threshold? Too high, yes. And more is being demonstrated. So in congenital heart disease, we usually use 40% as a threshold for severity. And more all the aortic regurgitation studies are showing that a threshold of 50% is far too severe. Yes, okay. So this same patient, you see, this is, where is the catheter? My catheters? Huh? In the PA, and what do you see? Yeah, look at the RV here. Severe regurgitation. Again, remember PR is really faint. This is a patient with severe pulmonary regurgitation. It just doesn't, you have to slow down your frame to see it, and this patient underwent a transcatheter valve, and you see how now you don't have any regurgitation. Can you see that clearly now? Yeah. Mm-hmm. All right. So in cardiac MRI, the one of the strengths in tetralogy flow is the RV size and function. It allows us to see in detail the outflow tract, very well defined here. And let me see if this is a stack across in a short axis stack. You can see here the RV in the RVOT, and I'm just going to. I think I have a larger picture. We'll go back to that. You can see here the patch, just like you saw in echo. And then we usually obtain RVOT stacks. And if you help me follow here, the myocardium, yes, this is the RV, right? And we follow the myocardium, contractile myocardium here all the way. And what happens here?
That's the patch motivation. The patch.
Yeah. Do you see any contractile function here? Huh? No. So this is patch material. Sometimes you'll see it may look very aneurysmal too. So when you interpret RV ejection fraction in tetralogy flow, you need to consider that. You need to consider that you have an area of the right ventricle that is not pumping forward.
Is it a patch or conduit?
No, this is a patch. Yeah. This is the patch all the way here. The annulus is right here. You see some remnants of the pulmonary valve here. This is the RVOT. This is a patch in the RVOT. Just this area is, Dr. Mark Gillivray used to call this a high school student. is present in class but not participating. So remember that when you critically assess your RVEF, because we use the RVEF to make to make decisions, and sometimes in a patient may have normal, the myocardium is contracting okay, but you have a huge RVOT patch that is dyskinetic that is going to affect your calculations. So usually I say the RVEF is that in the setting of this large of a patch in the RVOT. So we also do VSD stacks to look. Alicia does VSD sweeps. Our sonographers do sweeps to look for residual VSDs, and just real. This is another patient with tetralogy of Fallot. You can see how distorted, how different the anatomy can be. Again, this is the crest of the septum, and this is the patch, and you see the level of override here, and you see the residual VSD right there. So we don't see them very often, but we do look for them because they're present, and they have implications in what? When you have a residual VSD, let's say it's high velocity and restrictive, and it's not causing a lot of hemodynamic consequences, but still it's important because of what? This is a board question. Go on. When you have a residual shunt next to, in the vicinity of patch material, these patients need SVE profile. Yes, good job, Rasha, yes. Because this jet, even though it's not causing, may not cause, the QPQS is low and it's not causing hemodynamic issues, it's a prevented endothelization of your patch, yeah? Usually these are very high velocity jets. Okay, we really pay attention to the PAs. So in every study, we do angios, and when we see obstruction, CNIs across the branch PAs, because they can have those issues. We also look at differential blood flow in patients with hypoplastic PAs. We measure them separately on MRI. So we review everything that we need to look in tetralogy of Fallot. The one thing I'm going to add from here, from the trick, remember anatomy, surgeries, and sometimes a 3D SSFP can be very helpful. In tetralogy of Fallot, when you're doing an MRI, it will help you with the coronary origins that sometimes are frequently abnormal in tetralogy of Fallot, and has implications as you're planning as you're selecting patients for transcatheter valves. Because they can cause coronary compressions in patients who have coronaries going anterior to the RVOT. And with that, I'm going to finish 12:54. All right, questions? Yes, Priyanka. Yes, those are great questions. So in the adult patient that we saw, which is a very infrequent scenario, he got a pulmonary valve replacement, right? But in a kid, we cannot put a prosthesis in an infant because they're too small. They're just too small for that. First, they're not prosthesis that small, and then they will grow. So usually they do not repair the valve; they just disrupt it. Some centers right now are doing a single leaflet repair with some short-term potential, but we will see in the long run. But no, in general, these patients are left with significant pulmonary regurgitation due to a disrupted valve. Yeah. All right, yes?
This is a pretty informative talk, very helpful for echo boards.
All right, make me proud.
But as far as the American Pediatric Association goes, do they recommend getting echoes on all newborns in America?
Oh, no. Yes, no, not all newborns get, yes, no, get. In fact, there is, globally, there is a movement towards, do we check saturations in all the newborns at the global level to screen for congenital heart disease? Yes, but no. no. I think the pediatricians are amazing at physical exam and recognizing signs and yeah. Yes. Priyanka. Oh, yes. So very simplistically, when you have a VSD, means that there is a disconnect between or a missing part or a disconnect, right? A VSD could be a missing part of the ventricular septum, or it can be a disconnection between two different portions of it, yes? So here there is you see the crest of the muscular septum, right? That is not attached to the conal septum that is between the RVODs, and that is malaligned anteriorly, this place. So that's what leads to the VSD, that disconnection. And the movement anteriorly, the malalignment is what leads to the RVOT obstruction. Yes, so it's a malalignment VSD. If we want to be very technical, this type of VSD is called a malalignment VSD because you don't have a missing part of the septum. You just have a part of the septum that is not aligned with the rest. It's disconnected. Yeah. That's why when we're looking at that image of the residual VSD, you see the patch and it has a very infrequent direction, if you want, right? It looks like almost, or it's horizontal, if you want to call it in a way. All right, well, thank you so much for your attention.